Good evening, everybody. Welcome to the Wednesday evening webinar of Indian College of Anesthesiologists. Today's webinar is a special webinar. It's on operation theatres. That means we're going to talk to you all about operating rooms or operation theatres. We all know well our working place. Some people call OR or operating rooms. Some areas called operation theatres. Some may sometimes say operating cubicle. Apart from these terms, well, we used to qualify our working area with so many fancy names. Green OT, hybrid OT, digital OT, and sometimes we may go up to say positive pressure OT, negative pressure OT. Like that, we differ in addressing about our working place. But unfortunately, not many of the people know about what exactly we mean by each particular term. Today, we're going to clarify all these particular terms and how we should maintain an OT. OT, we want an efficient work. The designing of the OT matters, as well as the maintenance of OT matters in making it more efficient. And our efficiency depends on the workplace, as well as the convenience available in the OT rooms. And today, this particular webinar is moderated by Dr. S.S. Harsoor. Siddhamesh Harsoor is known to you all well. He was editor of Indian Society of Anesthesiology, later president of Indian Society of Anesthesiologists. Now he is an active member to Indian College of Anesthesiology. Apart from that, in his civil service, he was the principal of a medical college. Later, he became the director of medical education, and then he was director of publications, as well as curriculum development of Rajiv Gandhi University of Health Sciences. And he is the most smart person who may be able to convey to you all on this particular subject. He has written many times in the journals about the operating rooms and operation theatres, which one should know about. And he is aided today by an international faculty who are known to everybody and who has so well spoke on these particular matters to many number of people, many number of times at many places. And Dr. Harsoor will be moderating the session, and I request Harsoor to carry on.
Sir, thank you very much, sir. Good evening, one and all. Thank you very much, sir, for giving us this opportunity to present and clarify certain issues.
Harsoor,
yes,
please
sir.
Take over.
Thank you very much, sir. Thank you very much. Sir, thanks for a nice introduction, sir. I hope I am audible to all.
Yes, sir.
Yes, sir. Fine.
Okay. So at the outset, I would like to immensely thank our parent organization, Indian College of Anesthesiologists, and the president of ICA, Dr. V. Radhakrishnan, who mooted this idea and asked all of us to make a panel and then clarify all the doubts about the operating room or operation theater, cubicles and whatnot. So that many of our colleague anesthesiologists and other doctor friends who know, sort of a confusions about the operating theater, its setup, the safety practices, the air conditioning, all these matters we are going to discuss today in the next about 120 minutes, that is 2 hours. And I immensely thank Dr. Sanish, who is an academic coordinator for the Indian College of Anesthesiologists, and all the other office bearers of the ICA for having given us this particular opportunity. And in this particular session, we have got 4 speakers: Dr. Zulfiqar Ali from the Srinagar in Jammu and Kashmir. Then Dr. Balabhaskar is going to speak on safety of operation theater. He's a professor at Vijayanagar Institute of Medical Sciences, Bellary in Karnataka. And Dr. Priyam Saikia, who is a young and budding anesthesiologist, but highly talented. Dr. Priyam Saikia is from Guwahati Medical College in Assam. And finally, an eminent speaker, you all know Dr. Amit Shah, who is going to speak about the air conditioning and the ventilation aspects in this thing. So with this brief introduction, we'll begin with the first speaker, that is Dr. Zulfiqar Ali. I take immense pleasure in introducing Dr. Zulfiqar Ali, who is additional professor of neuroanesthesia at SKIMS, Sher-e Kashmir Institute of Medical Sciences in Srinagar, Jammu and Kashmir. And he's a very, very active and dynamic and a very, very resourceful person in the field of anesthesiology. He's a DM in neuroanesthesia from AIMS, New Delhi. And he has got more than about 100 publications in highly reputed journals, and a person with extraordinary knowledge all about the anesthesiology and the practice. And he is a great speaker also. And today he's going to speak all about what all the different types of operating theaters, the physical infrastructure associated with that, and what are all, as rightly Dr. BRK said, what are the terminology mean, like say the hybrid OTs, the digital OTs, the smart OTs, the green OTs, various terminologies are there. All these things are going to be clarified by Dr. Zulfiqar Ali. Over to you, Dr. Zulfiqar Ali. And before that, can I just request, there are some pre-tests like questions. I want opinion poll, the polling pad will be available to all the participants here, and the time given will be about 20 seconds to answer each questions. I'm going to read out the first question, that is, as per the operating room requirement guidelines, the recommended operating space area of a standard operating room should be around, there are 4 options. It is 300 square feet, 600 square feet, 1200 square feet, or 2000 square feet. Your time starts now. In the next 20 seconds, I expect many of the participants to give their answer. Okay, 15, 16 seconds, 17, 18, 19. Right. Okay. So that is the first question. Yeah, in that 19 members, that is more than 60% of our participants feel that it should be 600 square feet, and that answer is absolutely right. Okay, the next question. Next question is, which of the following statements is true? Minimum air changes in the operating room should be less than 10. The temperature should be maintained at 21 plus or minus 3 degrees Celsius. Relative humidity between 20 and 60 degrees. And the window and split AC can be used to regulate the temperature in the operating room, or all of the above. Your time starts now. Okay, that's end of the poll, and about 17 members feel that it is option E, that is all the answers, but the right answer is here, that is temperature should be maintained between 21 plus or minus 3 degrees Celsius. This we are going to elaborate why not the other window and split AC are not useful. We are going to explain in the next his talk. Dr. Zulfiqar is going to clarify those things. Okay, the third question. Which of the following statement is correct? That is, a hybrid operating room is a surgical room theater that is equipped with advanced medical imaging devices such as CR, X-ray, CT, and other MRI such units. Or hybrid operating rooms do not have a flexible patient positioning. The third option is minimally invasive procedures can't be done in a hybrid operating room. 4, the ceiling mounted imaging system may be more desirable in a hybrid operating room. and maybe more desirable than a non-ceiling mounted imaging system for an anesthesiologist? And the last option is none of the above. Can you just identify which is the right statement? Okay. At present, we have got around nearly 80 participants. And okay. Yeah, about 17 people, that is once again 16% of the people think that option A is the right, and that is the correct answer also. Okay, so the other things we were going to explain it in the next lecture. Next question is, the 1999 CDC guideline for prevention of surgical site infection states that the options, 5 options are there. Wear a surgical mask that fully covers the mouth and the nose when entering the operating room. Wear a cap or a hood to fully cover hair on the head and face when entering the operating room. Wear shoe covers for the prevention of surgical site infection. Or the answer is the A and D combination, or all the 3 are correct. Your time starts now. I wish more and more participants to take part in this polling. Never mind whether the answer is right or wrong. We are going to clarify the doubts. Okay, 38, 40 people. 40 out of 85 have participated, and they think that option D, that is both A and B, are correct. And the correct answer is also the same. I think majority of the people are fully aware of the CDC guidelines. Okay.
Sir,
Right. That is
towards
the
the end, we'll have a quick watch out for an
Zulfiqar.
audience quiz where audience will have to answer through the chat. So fastest person will get a certificate.
Yeah, this audience quiz will be held at the end of the talk, and all the participants can participate, and whoever answers the questions earliest, correct answers, will be awarded with the certificates. This will be at the end. Right now, over to Dr. Zulfiqar Ali for his talk. Are you ready, Dr. Zulfiqar?
Yes, sir. Yes, sir.
Please.
So are my slides visible?
Yes, yes, sir. You can proceed.
Yes. Please go ahead.
Thank you, sir. Good evening, everybody. Before starting, I would like to thank the Indian College of Anesthesiologists for starting this excellent initiative of teaching. This program has been going on for more than 1 year, and it's highly beneficial to all the anesthesiologists, particularly our postgraduates. My talk today will be focused on designing of an optimal design for an operating room. So if we see the traditional name as how the operating room has been previously named as operating theater, basically the word has come from the United Kingdom, and it started historically because the medical students, initially they were allowed to watch the various surgical procedures done in the form of various procedure rooms which were designed in the form of amphitheaters. But still, operating room is one of the most important areas of the hospital. And if we have an ideal operating room setting, which is safe for the anesthesiologist, surgeon, and the patient, it will help in reducing the morbidity and mortality to the patient, and at the same time ensure the safety of the medical teams and the patient who is being operated. An ideal operating room design has to be promulgated by a combination of teams consisting of civil, mechanical, electrical, electronic, and biomedical engineering teams, but without the involvement of anesthesiologist who is well acquainted with the physiology and physics. The design of an operating room will be incomplete. The anesthesia control time in an operating room is around 10 to 20% of the total case time, and it's mostly the surgeon control time. That's the operating time that is around more than 80%. But once we design an operating room, the 20% time that the anesthesiologist spends, it's just landing on and landing off an aircraft, and very crucial stages are involved. So once we design an operating room, both the requirements of the anesthesiologist and the surgeon have to be adequately addressed. Now, if we see the different zones of an OT complex, we have mainly to keep three things in mind once we design an operating room. What's the location of the operating room in the hospital? What is the flow of the patients? What's the staff that's working in the room? And what's the material that we are using for the particular surgery that's being carried out in the operating room? Based on these, most of the theaters, they have main three zones. We have the dirty or the outer zone as it's called, followed by the clean zone, and followed by the sterile zone. Now, how are these three zones classified? They are classified mainly on three parameters. The basic parameter is the degree of the cleanliness, which increases from the outer to the inner zone, where we have the sterile core, which is the most clean of all three areas. The second criteria is the bacteriological count, which is minimal in the core area. And then we have a decreasing positive pressure ventilation gradient, which increases from the inner zone to the outer zone. So we have to keep these things in mind once we design an operating room. So what's basically the dirty or the outer zone? The dirty or the outer zone, as all of us who work in the operating room every day, we know that the dirty zone, it mainly consists of the main SS corridor to our operating rooms, where we have the patient reception area and the waiting area. Then we have an entrance to the changing facilities for the staff. And we have to have a proper janitor area through which we can remove the waste material, and a dirty utility room where we remove all the soaked linen. In a desirable, ideal operating room, it's better to have entrance which is electronically controlled, and the various recommendations from various international organizations, they lay down that the reception area to an operating room should be having at least 52 square meters of area. Cultural issues are very important, particularly in the Indian scenario, where there has to be a separation of male and female patients, which may be desirable. And we have to have an adequate waiting space for our patients who are going to be operated in the waiting area. There are recommendations that if we have around 8 theaters, so we follow a rule of 1.5 bed space per theater. So we should have a minimum of 2.1 into 1.6 meters for each trolley or stretcher. At the same time, we have to keep in mind that once we have patients with infectious diseases, we have to ensure that these patients are having an isolated area so as to reduce the cross infection within the operating room. The second area of concern that's to be addressed while designing an OR is the proper development of a proper area for the staff. We have to have a proper area for our male and female personals, and then this area has to contain proper lockers. Most of the operating rooms in our scenario do not have showers, but they are also ideal in an ideal setting. Particularly, it is desirable to have a shower once the patient comes out of the operating room. One of the most important things while designing an operating room is to encourage a one-way traffic pattern. Once the staff enters into the operating room, the staff should enter from one lane, which is a clean lane, and then once he goes to the scrub station, gets scrubbed, where surgical scrub cloths, moves to the operating room, and once the procedure is over, there should be another ways out once the patient comes out of the operating room. A dirty utility room or a soiled room is very important. And in an ideal operating room setup, this is some of the images that I have taken from my hospital, where we have operating rooms which have been built around 30 to 40 years back. But even at that time, they have been built up very nicely. We have a dirty lane surrounding around 9 to 10 ORs. So this is the window in the dirty lane. I have focused, this picture is taken from outside the dirty lane. And now this picture is each dirty lane. It's just like a window that we create for a split AC, and it's having a double door. I have not been able to take proper pictures. So I have opened up the outer window that faces the dirty utility room, that is open. The linen has been placed in the window, and the door towards the dirty lane is closed. So once we open both these windows, there's a direct communication from the dirty utility room to the dirty lane. So the person who's involved in cleaning, he comes through this dirty lane. There's no contact with the operating room, and the linen, the soaked linen, gets cleared along with other utensils, along with other utility that has been used during the surgical procedure. Another area of importance while designing is the janitor area, where we keep housekeeping equipment in the form of washing station, and we keep an adequate supply of the supplies of use in this for the surgical procedure, and this has to be separate from the clean workroom. From dirty zone, now we come to the clean zone, and the clean zone, where in the clean zone we usually keep storage spaces for the sterile and the clean supplies. And we have to remember that this space has to be free from the moisture, and it has to be having an adequate temperature control, and it should be free from human traffic. There should not be more human cross traffic, which can increase the chances of the infection. It's in this area where we have a general purpose store, which contains space for portable X-ray equipment, stretchers, fracture tables, and warming devices. The medication stations are again located in these areas where we have drugs and routine medications. And then we have the anesthesia room, where we have built-in cupboards and workbenches where we place the various anesthesia-related drugs. Again, in the clean area, we have the recovery room, and the recommendations for the recovery room are that it should have an area of around 110 square meters, and we should have a work area of we should have around 1.5 to 2 beds in the recovery per theater, and each bed should have a space of around 2.4 square meters, and each bed should have a particular cubicle with curtains and service pendants for oxygen and suctioning. The scrubbing area is again important. We have recommendations that we have to have a scrubbing area of around 9 square meters. We have to have space for around 3 people who can scrub simultaneously. We have to have a glove and gown bench nearby. Once we scrub, the surgeon or the anesthesiologist, he should be easily be able to wear a gown and a glove, and it should be placed near the entrance to the operating room. The scrub sinks, they should be cleanable and disinfectable, and they should be ideally made of stainless steel so that they can be easily washed. They should be elbow operated, or if cost is not a consideration, we can go for electronic sensors. And at the same time, we should have designed them in such a way that there is minimal of splashing once we go for scrubbing during the wash. At the same time, there should be the sinks, they should have rounded margins so that once they are cleaned, they can be cleaned properly. There should be no sharp edges. The clean and utility room or the clean work room, this room should not be used for food preparation. And this room is the area where we have clean materials. They are assembled, which are used during the surgical procedure. Then there are some other areas which come under the clean area. We have the rest area. We may have a small pantry. We should not forget about the firefighting device rooms and the emergency exits, which may be very valuable in terms of once we have some natural disaster in terms of earthquakes. The rest area, they should be comfortable where the staff can come have food and drinks. Ideally, there should be a resting lounge, and a supervisor's office would be ideally should be nearby, one who can monitor the activities in the operating room. And at the same time, we should have an adequate area for the medical storage gas facilities, and should have some area designated for working on the frozen sections and storage of the blood. And once we are dealing with organ transplant, we should have an adequate facility for storage of the harvested organs. The most important area in the operating room where we should take caution is the sterile core. And here there should be a restricted entry of the staff. Whosoever goes there, he should be wearing a proper surgical attire. Hair should be adequately covered, and masks are required once we go into the sterile core. These are some of the ideal conditions that we should have in an operating room. The area of an ideal operating room, as most of our participants were already aware of this fact, that it should be around 36 square meters. The ceiling height should be around 3.2 meters. And we should have an additional 2 feet of ceiling if we are planting some X-rays, C-arm, or some radiology equipment through the ceiling. The cardiovascular and the neurosurgery OTs do have additional equipment, and we need extra space. And similarly, endoscopic theaters and plaster rooms, they can be smaller. The walls, once we designed, we should remember that the walls, they have to be bacteriostatic. It's ideal to have acrylic resin walls made of acrylic resins, and they should be easily washable with detergents. Similarly, we should have walls without cracks. There should be no open joints, no crevices, and there should be no dividers. These are the areas which harbor dust, insect, and bacteria, and may increase the chances of infection during the surgical procedures. Similarly, the floors, they should be around 2.5 millimeter of thickness. They should be anti-static, made of vinyl sheet, and they should cover up to the wall up to around 100 to 150 skirting margin should be made. And we should remember, this is not followed at many of the places, but in an ideal condition, all the corners in an operating room should be rounded so as to prevent harboring of dust and bacteria. The ceiling, it should be non-porous. Again, it should be scrubbable. It should be easily washable. It should not be perforated. The minimum ceiling height should be around 2.4 meters, but there are exceptions where we need to increase the ceiling height, particularly once we accommodate the lights, particularly in delivery rooms. Once we design the doors of the operating room, we should remember that they should be never made of wooden material. They should be made of material which are easily washable on daily basis. And ideally, we should be having the double door OT rather than a single door OT. Designing the illumination of an operating room, the lights, they should be bright, they should be evenly placed. And most of the lights, they should have natural colors. Again, the lamps, as we saw the walls, ceilings, and the floor, the lamps should be also be easy to clean. They should not collect any dust. And we should fix lights in such a way that there should be no glare once we are operating. This operating uh, lights usually follow a concave reflective pattern shell on which they are aligned. And once we follow this pattern, they widen the illuminated area. And the advantage is that the shadow is minimized, the shadow of the operating person is minimized in the operative field. At the same time, we should remember that these lights, they should be made of ideally of tungsten. And this makes it easy that once we use lights made of tungsten, it enhances a better vision into a deep wound. The intensity of the light should be around 3000 lumens. And we should remember that all lights, they should not transmit heat in a downward direction. And at the same time, if there is minimal transmission of heat, there may not be drying of the tissues over the wound, and it may not make our surgical and anesthesia teams, who most of the times it's our surgical team who's operating under the lights. And if there is no transfer of the heat, our surgical team will be comfortable. Scavenging systems should be optimally designed. Both active and passive scavenging system can be used. And the NIOSH guidelines lay down that we should have a time-weighted average concentration of nitrous oxide, which should be less than 25 parts per million. Now, coming to the different operating rooms that are in vogue nowadays, we have the modular operation theater. So in a modular operation theater, we have the OT table, which is having a laminar airflow. And once we have a modular operation theater, the laminar airflow, it purifies the air within the OT through air handling units and the HEPA filters. So we have a centralized cooling system. We control the temperatures in an ideal way, and it has been seen that if we are using modular operation theaters, there is minimal or no growth of bacteria in the operating room. At the same time, the advantage on the health and the safety of the working staff is immensely increased. And at the same time, it has been seen that there is a dramatic decrease in the incidence of surgical site infections. Coming to the smart operating rooms, the smart operating rooms, what they do is they collect the patient's information from various sources through various digital devices, and it is incorporated into a central device that is placed within the operating room. So this information may be in the form of the basic investigations as hemogram, or it may be advanced imaging in the form of CT scans, MRI imaging, that is incorporated in a central device that is placed in the operating room, and the surgeon uses it. This form of technology has revolutionized. And what we do in the smart operating rooms, if the patient has undergone a CT or an MRI, which has been done one day before in the MRI suite, and the patient correlates this image with the intraoperative findings, and many a times there is a 3D reconstruction of the image, and this helps in better dissection and better surgery, so as to improve the clearance of the underlying pathology for which the patient is being operated. In the digital operating room, what we do is, again, we previously at even many places, even at my place, we light the scans of a patient on a light box that we have mounted on the walls. But now this is being replaced in the digital operating rooms by a device which incorporates a video integration of the various images and videos from the pre-operative period, and all this data is displayed on a single device. What happens? The digital OR setup, it acts as a central hub for the information of all the all imaging modalities or any information. And then once the patient is operating, the necessary remedial steps are taken. Most of this information, preoperative, intraoperative, and immediate postoperative, it's transferred from this device, which has its center in the operating room, to the hospital IT system, where it's centrally stored. In the hybrid operating room, what we do is we use again the imaging modalities like CT, MR, or C-arm. They are used during the surgical procedures, and the advantage of this hybrid operating room is that patient doesn't have to be moved during surgery. Now, we have mainly three types of hybrid operating rooms. We have one room fixed operating hybrid operating rooms where we do the maximum integration of a high-end MR scanner is done. What we do is that the patient is taken from the operating room to the adjacent OR, and an imaging is done during the surgery. If there is inadequate clearance, the patient is again brought to the OR and necessary steps are taken, and again the patient may be taken for MR to ascertain whether the necessary corrections have been made. Then we have 2 or 3 room configurations where the patients have to be transported to adjacent rooms. It's not in continuity to the operating room, and this type of 2 or 3 room configurations, it increases the inaccuracy because there are possible movements once we use this reference system. And the best form of a hybrid OR that has been developed, where we have the navigation ORs, particularly this has revolutionized the neuro navigation procedures, which are in vogue at many centers now in India, where we have operating rooms with mobile system. The patient, he remains in the operating room, he remains on the operating table, the imaging system is brought to the patient, the necessary images are taken, and it's verified whether there is adequate or inadequate clearance. The operating surgery continues as per the requirements of the patient, with the imaging modality being brought into the on the operating table as and when required. Then we have the green operating rooms. Green operating rooms will be the future of the all anesthesia working environments, and this is what we should focus for in the next years. It's a operating room where we have an ergonomic control of airflow. We have an ideal OT setup where we use volatile agents in a proper way with a proper scavenging system in place, and we have, once we use these systems, we have an ideal environment for not only the patient, we have an ideal environment for the surgical teams and the operating surgeon. And in a green operating room, at one side, if we use a proper scavenging system, we use an ideal operating table with a proper air handling units, with a proper ventilation. At the same time, we should have an audit with a measurement and quality assurance mechanism in place to see that whether we are following the proper norms. Thank you.
Yeah, thank you very much, Dr. Zulfiqar Ali. You have given an excellent overview of all the topics that are in a discussion today. The current days, a lot of newer things are coming up, and you elaborated on those issues quite clearly. And also, for the benefit of the participants, just let me inform you that since the topics are divided, there is a possibility of some kind of a overlapping that is likely to take place. For example, how the laminar airflow functions, or what the temperature of the OT should be, or even the scavenging system, what he is telling. This will be once again covered in the next this thing. And we will have a common question answer session at the end of all the 4 speakers. Okay, thank you, Zulfiqar. Just be waiting, and we will, once our other 3 talks are over, we will be answering the questions that are available in the chat box.
Fine, sir. Thank you, sir.
Thank you very much. Now we'll move on to the next talk by Dr. S. Balabhaskar. Balabhaskar, you know, I think he does not require any introduction as such. He is currently a professor of anesthesiology at Vijayanagar Institute of Medical Sciences, Ballari. And he is the present chairman of the academic committee of Indian Society of Anesthesiologists. And formerly, he was the president of ISA during the year 2019 and 20. And also, he is one of the best editors of Indian Journal of Anesthesia. He has really improved the status of a journal during his tenure. By appreciating that work as an editor, the Rajiv Gandhi University of Health Sciences has appointed him as the editor for its university journal also. And of course, he is also a very active clinician and academician. He is currently involved in the formulation of Indian guidelines in various issues. He's a lead person, and already his efforts have paid the dividends in the form of the guidelines for fasting and feeding. I think most of you are already aware of it. He has got a lot of more than about 50 publications in various reputed international journals, index journals, and he's one of the core committee member who introduced this concept of these workshops for the benefit workshops for the research and publications for the benefit of all our young generation, so that whatever he observed during the editorship as a flaws that were seen in the young publishers, so he has tried to improve upon, and he has done a great job. So I request Dr. Balabhaskar to join the team. Before he starts his talk, we will have another 2 questions like the previous one. The voting pad will be there. Kindly answer in the voting pad. I know some of you are answering in the the chat box. Kindly use the voting pad. First question here is the safe humidity levels in the OT. Option, there are 4 options. Is 20 to 40% humidity, or 20 to 60%, 20 to 80%, or 20 to 100%. Voting pad is available. Please use voting pad in the next 20 seconds. Your time starts now. Okay, Sanish, can you just open the voting pad? Dr. Sanish?
One second, I'm doing it.
There are some technical issues. It will be rectified almost instantly. Okay, so the results say that about 31 people have participated out of 110 plus another about 30, nearly 140 people are there. But the option B, that is the majority of them feel that, 61% feel that option B, and that is the right answer. Okay, shall we move on to the next question? The next question is, of course, the implementation of radiation safety is very stringent these days, you know. There is a reduction in the disease of a majority of the organs. Despite that, some problems do occur in the operating room and the radiation safety practices. And those problems, which is the one problem which is still prevalent, that is fertility problems, or a hair loss, cataract, or thyroid problems. Which one of this is seen despite following the radiation safety practices?
There is some problem with the voting pad. We'll take the answers from chat, sir.
Okay, chat box voting pad problem is there. He will rectify it in the next for the thing, hopefully. Please answer in the chat box. Yeah, I'm seeing A, B, D, A, C, A. Okay, right. The right answer is, not many could answer it correctly. Yeah, answer is Arshina. Yeah, it is a cataract that is still prevalent despite following all the radiation safety. The other things are to a great extent they are taken care of. The fertility problems, hair loss, and thyroid problems. And yeah, I just told you at the end, once again, there will be a earliest person to answer the quiz. There will be another 3 questions at the end of the talk. So we will watch out for that. And over to Dr. Balabhaskar for his talk on the various safety issues that are involved in the operating theaters. Like he is going to talk about the issues of how the fire safety is practiced, what are the other maintenance, and especially the electrical leak and electrostatic flooring, what is required. And also he will be touch upon these other safety devices like pressure gauges in the cylinders, or that is OT pendants, how they are there, and with a brief touch upon the exhaust in the OT system. Over to you, Dr. Balabhaskar.
Good evening to the office bearers of Indian College of Anesthesiologists, all the co-participants for today's program on operating room, and all the viewers for this evening. So there could be some overlap between the presentations amongst us, the 4 speakers today. And while I'm going to speak for next 20 minutes, there could be something about factors other than safety for better understanding of the various concepts. So why are we talking about safety in operation theater? Because we as anesthesiologists spend most time in the OT than any other physician. And very simply put, apart from what we do, we are also concerned about the temperature, humidity, ventilation, and noise. Of course, we do use medical gases, and majority of us are generally involved in planning and management of operation theaters. In fact, the Anesthesia Patient Safety Foundation was the first specialty division or a society or an organization which talked about the safety of the patients, and it was first launched in 1985. So I'll be talking about various sections, something about the medical gases which we use, the OT environment which I was talking about a moment ago, the electrical safety and the fires and explosions, and overall staff management. So normally the gases which we use in the operation theater are oxygen, nitrous oxide, and air, and suction apparatus and suction connection, and nitrogen would be sometimes used. And oxygen, there are recommendations with respect to the use of the medical grade oxygen as compared to the industrial grade oxygen. And we also have various standards with respect to the manifold room, where we talk about the banks of cylinders for oxygen, nitrous oxide, the types of regulators, the gauges, and everything. And we also talk about the reserve oxygen cylinders as a safety measure. Whenever the main pipeline supply fails, we are going to use the reserve cylinder, normally as size E cylinders. Even the bulk supplies which are there in a hospital are based upon the utility for that particular setup. So what is done normally is, it is at least 1 day's supply is ensured, whether it is from the manifold room or whether it is from other sources. And storage recommendations are also available, which we follow diligently with respect to the cylinders within the manifold room, and also with respect to the smaller cylinders, including size E. So as I told you, size E cylinders are taken as the reservoir cylinders. So when we are going inside the OT or we are going to start a case, anytime the first thing we have to do is check the contents and volume of that particular gas, especially oxygen. And we also have learned a lot about the safety systems related to each of the cylinders. Broadly speaking, we know about the pin index and the color index also, and the things which go into its manufacture and its usage safely. So these are the various colors allotted to different gases. Even medical air is also obtained through the air only. Basically, it is more purified form. Cylinders are also available, even though generally they are from the various compressed air generators, which are available in many of the hospitals. Medical air is popular and is gaining popularity also because nitrous oxide has got certain environmental adverse effects. It has got effects on the green gas emissions. And we have indications where specifically nitrous oxide can be replaced with compressed air. And as part of the MGPS or medical gas pipeline systems, we also talk about vacuum generally. If it's in a major setup, we should be having 2 units. Each one should be able to perform independently, and the other one will be basically as a backup also in the event of any emergency. So of course, surgeons would use for various purposes, and we also would be using, for example, to suck out the throat or remove the vomitus and other things in general. So can this the suction apparatus be used to scavenge the anesthesia gases? Okay, they can scavenge the whole system within the OT, but what about the anesthesia gases per se, which is our domain? It is possible only when we have got a regulator with a float indicator, but there are risks there. If there is excess suction, there is inadequate patient ventilation. If you do a lesser suction, there is risk of retention of waste anesthetic gases. With respect to the pipelines also, there are standards. We have got the color coding for the various pipes, the sizes, the material it should be made up of. We have got non-corrosive material, we want seamless connections and all. And we also know about the hoses configuration and distribution systems. And there are recommendations that pressure drop across the system shall never exceed 5 psig. And we also know about the areas where the gas is reaching the patient towards the machine, the quick coupler, the DIS and NAC systems. So all of them are based upon the safety requirement in the operation theater. There are important recommendations with regard to this from a National Fire Protection Association USA and the Medical Gas Health Technical Memorandum from the Department of Health in the UK. And we have recommendations in India from CDSO and from the Petroleum and Explosive Safety Organization and the Ministry of Commerce and Industry. So it has taken shape and we have got well-made recommendations, guidelines available now. So with respect to the pipeline, it is advisable to have as a safety measure pipeline alarm systems. It could be one with a digital display of the pressures, or it could be without digital display where there are preset alarms. So if the pipeline pressure goes up below a certain level, it will start giving alarm. These alarms should be present at the central level or near the manifold and in the area where it is being distributed. For example, in the operation theater, PSU, pre-op holding area, etc. And it should be normally giving low pressure alarm with respect to low supply. And it would also give high pressure indication because of pressure regulator issues. Machine safety, I am not going to the details because all of us know as the end users, we have gone ahead a lot with the previous decades. You have got more safer anesthesia workstations now as compared to the older systems. And some of them can be overcome and some of them cannot be overcome. For example, FiO2 sensor is useful or of utility only till the point of sensing. Okay, for example, if you have put it in the proximal part of the endotracheal tube, at the tip, what is happening, we don't know. And beyond that also, we don't know. But safety is still safe only. Then the ceiling pendant system. So it looks beautiful, ergonomically good, but it is also within the interest of safety and isolation with respect to the electricity also. Normally, 2 ceiling pendants are used, one for medical gas pipeline systems and one for surgical team. The anesthetic pendant is normally fitted at the right and top head end of the OT cot, and the surgeon pendant is at the left and the bottom end of the OT table. And LED OT light is normally fitted at the center of the room. These anesthetic pendants are generally retractable with limited lateral movement. Sometimes there could be shelf for monitoring equipment also. It's always, it normally allows for oxygen, nitrous oxide, air as outlets to be there. And scavenging terminal outlets will also be there. And at least 4 electric sockets should be allowed in this pendant to operate the machine and the monitors. Then I was talking about our own environment within the operation theater, like temperature, humidity, ventilation, noise, and ionizing radiation. They also have got important safety aspects. So in fact, the temperature should be a balance of comfort between the surgeon and the physiological requirement of the patient. And in general, it should be a neutral temperature because it is discomforting for the surgeon with with all the gowns and the aprons and other things. We may need to slightly reduce the temperature. So normally it is kept at 20 to 24 degrees Celsius. Hypothermia is a risk for the patient, and you should actively and passively monitor against hypothermia. Humidity is an important part, because whenever there is humid climate, there is a risk of infection. It is advised to maintain humidity between 20 to 60%. Anything below 20%, it represents more of a dry air. It promotes airborne mobility of particulate matter, which could be a vector for infection. Anything more than 60% means it's more damp. It can affect the integrity of various barrier devices which we use in the perioperative period. In fact, the American Society of Heating, Refrigeration and Air Conditioning, ASHRAE, and the APSF, Anesthesia Patient Safety Foundation, have also expanded on the reasons why we should be maintaining it between 20% and 60%. Ventilation per se, I am not going into the details, because OT ventilation will be taken up by Dr. Amit Shah today. OT ventilation per se will not be useful for the waste anesthesia gas disposal, because when you talk about OT ventilator management, there is always there is a recirculation. 80% of air is recirculated with 20% of fresh air. So if it is still required, we may try to use it. Otherwise, you should be having a separate waste anesthetic gas scavenging system. Even after using gas scavenging, there could be some leak into the operation theater, but purpose is met, and the small amount may be made, can be removed by slightly positive air pressure to drive it away within the operation theater. Scavenging is actually the most important step in reducing trace gas levels. It will lower the ambient concentrations by up to 90%. So the planning must be done before the OT is constructed, and whether it's an active or passive type of scavenging, where it should be located, how many should be located, should all be decided beforehand. So this is the way a scavenging system assembly is connected towards the APL valve, and you can see normally the purple is the waste gas scavenging system. Noise is another problem within the operation theater. Apart from human noise, people talking too much. OT noise normally is about 70 to 80 decibels. But if surgeons are using, for example, orthopedic care chisels, neurosurgical drills, and other things, the levels could go up to 125 decibels. So the human subjects can start experiencing pain, and definitely a sort of hearing protection would be required in such situations. Ionizing radiation would be a risk, especially when you are undertaking diagnostic or therapeutic procedures, where we are there as staff. So there are various amounts of absorption of the ionizing radiation, and we should try to protect our cells, especially eyes, thyroids, and gonads and all are more vulnerable. And we should monitor the radiation levels. If the exposure is more than 40 REM, we should monitor, and we have got the common method where we use a film badge or dosimeter, and we can have even the lifetime exposure being assessed when we work in such places. How can safety be ensured? We should see that the exposure is as low and as reasonably practical. The ALARP principle, where you have to check the time, distance, and shielding. So definitely the time of exposure should be reduced as much as possible. The distance between the beam and the provider should be beyond, ideally, 6 feet and about 1.5 meters. Within this, it is more exposure is more risky. Shielding is the most reliable form of radiation protection. So we use leaded aprons, we use thyroid collars, and we may also use glasses. Definitely, there could be in some areas, there could be physical shields where somebody can go and stand behind and be not exposed. Despite the use of shields, it is found that the incidence of radiation-induced cataracts have not come down. So it is actually increasing in people who work in interventional radiology. It is advisable to use the goggles against the ultraviolet radiation. It is available upwards of 5,000 in Amazon also now. Electricity hazards in the operation theater. So generally, proper grounding of all the requirements is needed as part of safety measure, except the patient, because he is the one who is going to be operated upon. And circuit breakers are desirable to avoid overload and ground fault. Generally, power lines that are used inside are about 110 volts within the operation theater. There could be some isolated power systems wherein the transformer can be used to ground electricity so that there is no risk to the patient and the machines. And when you use these devices, they are made in such a way that there is no interruption of power, so that we can continue the life support systems for the patients. If there are no pendant systems, we can still use wall outlets installed about 1.5 meters above the ground. we have to use explosion-proof plugs, and multiple outlets must be used from different electrical line sources. And we should always beforehand decide how much of is the load, electrical load in the operation theatre based upon the material, equipment, and the patient turnover. And there should always be a power backup with automatic two-way changeover facility. There should not be time delay. All said and done, taking all the precautions, there could be leakage current, which is part of all electrical equipment. It is normally imperceptible to touch, less than 1 microampere. But if current bypasses the high resistance offered by the skin, and if at all it is directly applied to the heart, as for example, an exposed patient, currents as low as 100 microamperes are called micro shock, may be fatal, and maximum leakage allowed in OR equipment is about 10 microamperes. So these microshocks can also affect the cardiac pacing wires, and invasive monitoring catheters and myocardium can be involved. In fact, blood and normal saline serve as very good electrical conductors, and such a situation, microelectrocution can sometimes be fatal. So we should try to protect the patient and us from electrical shock. Complete patient isolation is definitely not feasible, because I told you he has to be the one who is being operated. So we have what is known as an isolation transformer, which is kept in many of the operation theaters. I will not go into the details, but which are available. But we can have some of the electrical measures related to line isolation, which is normally built into the circuit box for the operation theater. And the remote can be present somewhere inside the OT if the circuit breakers are outside the OT, and it may be on the wall of the OT also. It is very safe. If it is active and connected, a person can stand with bare feet on the wet floor and touch an outlet wire with little chance of being harmed. But this is subject to, all the other things being strictly followed. In such a situation, even line isolation cannot provide complete protection. In fact, the US NPFA 99 Healthcare Facilities Code gives classification of the various categories of the electrical equipment system with respect to their importance. Category 1 to 4. Category 1 is refers to the failure of equipment or system which are likely to cause major injury or death to the patient or the caregivers, those around. Category 4 is those systems where failure may not have any impact upon the patient care at all. So we should be deciding the importance of electrical items in the OT. And surgical diathermy is one another equipment which may produce some problem to the patient. For example, they generate high frequency, ultra high frequency electrical current. It passes from a small active electrode to the patient, and once it goes through the patient, and then it exits through a large patient electrode. It is the patient pad which we use normally in the operation theatre. There are certain risks with this. Current passing to the patient to a contact of small area may produce a burn, and current flowing through a heart, in the sense through a malfunction of ICD or cardiovascular defibrillator, can precipitate problems. For example, if to avoid the burn, what we should be doing is allow for proper return of electrode placement, avoid processes and bony protuberances when we keep the pad, and you have to see that there is elimination of patient to ground contacts. For example, the lithotomy pole or exposed steel surfaces and other things. And with respect to protection of the ICD and cardiovascular defibrillator, we can place the return electrode as close to the surgical field and as far away from the implanted cardiac device as practical. And generally, we are advised to avoid monopolar cautery because they are more dangerous. In fact, the newer electrosurgical units are better in this respect. They may also have a separate isolated power supply. It provides a second layer of protection, and they are capable of detecting poor contact and also give an alarm system. So there is a risk of surgical fires when you go beyond this also, and the patient can have thermal injury, which can happen in 1 in 87,000 cases. So for this purpose, we need a activation of a fire triangle. That is, there must be a fuel, there must be an oxidizer, there must be an ignition source or the heat. So in fact, this is picked up from the textbook of Morgan, where this is a list of various factors. There are the various flammable agents are the fuels: alcohol, fluorexidine, benzoin, intestinal gases, and other things. Gases supporting combustion: nitrogen, nitrous oxide, and oxygen. Ignition sources could be lasers, surgery, fiber optic light sources of the teeth, etc. So we have got very nice, the printouts and posters which are available from Anesthesia Patient Safety Foundation about the fires and how to counter them. So don't fuel the fire. The fire triangle, it says, is a triangle of oxygen, fuel, and ignition source. And we are the ones who are responsible to see that these are managed properly. We should learn to recognize early signs of fire, have carbon dioxide fire extinguishers ready, and saline or water solution also available. And we should also participate regularly in operation room team fire drills. And in fact, if you have used a prep like alcohol and other thing, there are advices regarding how long you have to wait before you drape and how long before you start using an electrocautery, and what the recommendations with respect to use of oxygen, because oxygen is the one which is going to support combustion if there is an ignition. So all these things and the volumes which are more dangerous or can precipitate fires are also given. In fact, the APSF also gives an operating room fire prevention algorithm. For example, if there is a head and neck surgery and you are going to use an oxygen source and you are going to use a cautery. Okay, so if it is not there, it is safe. You can go ahead with the surgery. But if you are going to have all these things, nurses and surgeons have to judiciously use alcohol and follow all the protocols. And there should be good communication between the nurse, surgeon, and the anesthesiologist. So when you go to the next step, if you have to decide whether patient indeed requires oxygen supplementation. If there is no requirement, and if he is okay with only room air, and even safely you can give sedation, there is no problem. But the patient needs oxygen, and the patient needs more than 30% oxygen concentration to maintain oxygen saturation. If it is not, we can use blenders of air, or so that the oxygen concentration is less than 30%. If oxygen concentration requirement is more than 30%, you have to secure the airway with endotracheal tube or supraglottic airway devices. So there are multiple recommendations used on this. It's a very nice poster you can download and paste in our operation rooms. And in fact, APSF has got a very nice video which is available on prevention and management of operating fires. It is about 18 minutes video. We will, if there is time, we will have a look later on. But anyway, we are supposed to take all the precautions, including perform drills and team role allotment for specific protocols, also maintain a good communication and other things. And always try to see that oxygen as an FiO2 should be kept to as minimum as possible. See and individualize for each of the patient. Laser safety is another one in the perioperative period. In intraoperative period, whenever laser is used, there is a risk of fires, and we should be very careful, especially as anesthesiologists. It depends upon the type of laser, the wavelength and the focal length with respect to the fire. So any warning signs must be clearly displayed before the start of the procedure itself, and all the personnel in the vicinity must use an IVR. And if you are using a nasal cannula or face mask, even for the patient, if the site of surgery is above the level of the xiphoid, so there is oxygen around the face, and if you are using a cautery, or there is always a risk of fire. And if you are using alcohol-based skin preparations also, this is a risk. So if indeed there is a fire, we should always try to put it out, keeping the safety of the patient and rest of the personnel in mind. We should check the patient, the airway and other areas of the OT where this is arising. First of all, airway fire is the most dangerous one. We should stop delivery, turn off the flow meter, disconnect the circuit from the endotracheal tube, and even the endotracheal tube can be removed. Sterile water and saline can be splashed into the airway to extinguish any active burning embers. Then the tube that is removed must be checked for any the pieces or disfigurement or any component being missing, and use air next. Then you should try to assess what has happened to the patient, and always try to see that fire extinguisher is available to be used around the patient also. So there are important recommendations from NABH with respect to the requirement of the fire safety measures, depending upon the size of the hospital, the construction and everything. And even there is an updated report by ASA, Task Force on Operating Room Fires also. Very nice steps are discussed related to how we should handle, including important is communications among the personnel within the operation theatre. Choice of fire extinguisher, normally there are different types which are available, the powdered ones, the carbon dioxide one and other thing. But carbon dioxide is the most optimal for operation theatre because it is readily available and economic to use. And it is not harmful to the patient when in the event of an intraoperative fire. Where should it be kept? It is normally kept within 75 feet of any working location, near the main door and on the left. And little bit about the flooring. Any flooring which is used in the operation theatre should have some important characteristics with respect to its imperviousness, smoothness, slip resistance, fire resistant properties, then diet retention and control considerations, then ease of cleaning, low maintenance, and strips and falls protection, STF protection. So generally, vinyl, PVC, rubber, terrazzo, and epoxy resin systems are all available, apart from the hard stones which were used previously. But generally, for OT, vinyl flooring is preferred. There are problems with both light colors and dark colors. So light colors will reflect more light, and so that it will deteriorate the appearance. Dark colors will absorb downward lighting and can alter the color spectrum. Pure or bright colors will show staining more than dull colors. So the choice should be a balance between these things. And even anti-static and conducive flooring, we had been discussing about it at more about 1 or 2 days ago, 2 decades ago, very actively. Anti-static flooring reduces the risk of static current. Conducive flooring is the one which absorbs the electrical charge. So you please note the difference. And this conducive flooring, in the conducive flooring, if you are using a rubber-soled shoes, there won't be any effect. Okay, only if you are walking barefoot, it's going to make a difference. And in general, because we are not using the inflammatory anesthetic agents and techniques, anti-static flooring is no longer required in modern operation theatre. And even acoustic properties of flooring is also mentioned. It should never produce sound when we walk on the floor or equipments are being drawn on the floor. And there should be even no reflection. And skirting in the operation theatre, there is advice for a minimum of 15 centimeter tall skirting to avoid damage and marking from cleaning and field equipment. Friction should also be minimal. In fact, it is said vinyl, rubber, and linoleum provide least rolling friction when something is moved, but others may be more useless. In fact, there are guidelines from International Health Facility guidelines group about the flooring also. It is very comprehensive. Even the country-specific advice is also given. And NSW Health has got a very good literature about the floor coverings in healthcare buildings. And finally, a little bit about the staff management. So we talked about many of the equipments, definitely, but staff management, one example is again given to a pattern which is followed by the aviation industry called Crew Resource Management CRM, which is dependent upon the about 7 principles. For example, adaptability and flexibility, then assertiveness, then communication, decision making, leadership, analysis, and situational awareness. So these principles have actually been indoctrinated into the cmos.gov, Centers for Medicare and Medicaid Services website and the system, and the Joint Commission system also. And all said and done, this is what we have discussed, and we should be following all the guidelines set by the accreditation agencies because they are well thought out and based upon the best practices. But sometimes the accreditor's expectation may be too much, and practice and there is difference between the recommendations, guidelines, and mandatory rules. We should be able to segregate all these things. And if there is some, some confusion from the level of an administrator or from an end user also, we should always be able to appeal against a particular process which may not be extremely suitable for the particular setup from the end users. And NABH has also given certain recommendations in terms of the documenting. Documenting is also always a part of safe management of operation theatre. In the care of patient, item number 13, A to J, about 9 points. It has got discussion about the data keeping. Starts from the consistency in the initial record keeping to pre-anesthetic evaluation, pre-induction, consent, monitoring, anesthesia record, post-anesthesia monitoring, shifting, infection control policy, and reporting of intraoperative adverse anesthesia events and data management have also been advised by NABH. So I'm not talking about the drug errors and precautions because it's an entirely big chapter. And definitely this surgical safety checklist is the one which is very actively used across the world, wherein we have should have a good communication loop between the surgeon, the nurse, and the anesthesiologist with respect to effective management of the patient for surgery. So thank you very much for the patient hearing. This is in a summary because material is exhaustive, and I will advise you to go through many of the recommendations with respect to the safe practice in operation theatre. Thank you. Good day.
Thank you very much, Dr. Balabhaskar. I think excellent presentation. You virtually covered the entire gamut of the safety precautions, because safety is the first thing, and I'm very proud to say that the Anesthesia Patient Safety Foundation is the first ever organization to discuss the safety of the patients among all the other medical faculties. And you have picked up quite a few of the points from that, because ultimately what matters is there are two things. One is our medical electronic equipments and used for the safety of the patient and used by the patients, like say defibrillators or such things, and the fire prevention. These are the two important things which you have covered very nicely. And quite a good coverage of NABH, ASHRAE guidelines, and IPS standards, APSF, all the things are there. Any questions in this regard, we will take it at the end of that. And now we shall move on to the next topic that will be by Priyam Saikia. Priyam Saikia is a young and dynamic assistant professor working at Guwahati Medical College in Assam. And he's one of the brightest students I have seen. A gold medalist at his undergraduate level, and he has been recently awarded with the best peer reviewer, because he has got a tremendous skills in the peer reviewing the articles that are submitted to our Indian Journal of Anesthesia and even other ones. And also he is active in the organizational work as a secretary of ICA Assam chapter, and he's a voracious writer also. There's already more than about 30 publications in peer-reviewed index journals. And here we are here to listen to him. He's going to talk about what the routine cleaning of OT should be, and how to sterilize the anesthesia-related equipment or other equipments, and what is the role of this ultraviolet germicidal irradiation many of the theaters are having, including he will touch upon the biomedical waste management, because that's not covered by the Dr. Balabhaskar's talk. And also, he will talk a few words about the operation theatre etiquettes to be followed by all the healthcare personnel. Dr. Saikia, you are ready, I suppose.
Yes, sir.
And shall we go to the questions first? Few of the questions he has presented. And
we'll go ahead with the talk, sir.
We'll go ahead with the talk, and questions there is some technical issues, and we will try to put those questions for audience polling at the later date. Over to you, Dr. Priyam Saikia.
Okay, thank you. A very good evening to the office bearers of ICA, moderator sir, my co-speakers, and the attendants. Today I'll be speaking on operation theater and sterilization requirements. I'd like to declare that I don't have any conflict of interest pertaining to this presentation. The images are taken from sources available at public domain, and kindly consult your local, district, state, or national guidelines for any clinical query related to sterilization and disinfection in OT.
Excuse me, Dr. Can you go to the slideshow mode?
Okay. Is it okay now?
Not yet.
Slideshow, the edit mode is there. Slideshow, yeah.
Yeah.
No, or else at the bottom it is there. You can
leftmost button, starting from beginning. Oh, that one.
Okay, thank you. I'm so sorry about that. Yeah, so for next 20 minutes or so, I shall be touching on some of the terminology and basic concepts. Then we shall be discussing a few points about routine cleaning of operation theater, preparation of instruments for sterilization, anesthesia-related equipment and their sterilization or disinfection, then sterilization of OT linen, a few points about the anesthesia scrub that we wear, chemical disinfection, ultraviolet germicidal irradiation, microbiological monitoring, and then I will conclude with a few points about disposal of biomedical waste and operation room etiquette. If you look into the pathogenic organisms that can cause surgical site infection, or rather any kind of infection in a susceptible host, they can be lipid enveloped viruses, vegetative bacteria, fungi. They are quite susceptible to the disinfectant that are commonly used. Then we have some non-enveloped viruses like polioviruses, mycobacteria, coccidia, bacterial spores, and prions. These are pretty resistant to the disinfectants that we use. In fact, prions and bacterial spores are some of the most resistant pathogenic organisms. Prion is not an organism, pathogenic material that is known to us. So for the what we are trying to achieve during OT sterilization is to decrease the bioburden on either the environment or the surface or on the equipments. The first point is always cleaning. Cleaning removes the dirt and the soils. Then if you want to decrease bioburden further, what we will do, we will go for disinfection, which is going to remove the microorganisms. And because spores are very resistant, we will be using sterilization if you want to reduce the bioburden more. Cleaning is defined as removal of visible soil, whether it's an organic or inorganic material, from the objects and the surfaces, and it is normally accomplished either by manually or by mechanically. We shall see to that in later slides. Then the next process after cleaning is disinfection. It is the process that eliminates many or all of the pathogenic microorganisms except bacterial spores and prions from inanimate objects. And sterilization is the process that destroys or eliminates all form of microbiological life, including bacterial spores. When we say sterilization, it simply means that there is a reduction of more than 10 to the power 6 log of colony forming units for most resistant bacterial spores. That means if an instrument is sterilized, the chances of survival for bacterial spores is much medium.
If not voting pad. So
yeah, because we have got,
and also before the
Harsu sir, do I continue? Yeah, because we have seen that the susceptibility of various pathogenic microorganisms are different. That is the reason why we have got 3 levels of disinfectants. The low-level disinfectants, they cause destruction of the lipid envelope viruses, most of the vegetative bacteria, and some of the fungi. The intermediate level disinfectants, they destroy all this along with this most of the fungi and most of the non-enveloped viruses along with the mycobacteria. The high level disinfectants, they destroys almost all of those microorganisms except bacterial spores. There are some high level disinfectants which when given enough contact period that can even destroy bacterial spores, and then they are known as chemical sterilants. We all have been to OT. We all know how this situation is because there are so many items inside OT. Because some items is inside OT, that does not mean that all has to be sterilized. So we always get confused which ones to sterilize, which ones to undergo disinfection, and which level of disinfection, whether it is high, intermediate, and low. Spaulding has given a classification regarding the items that will come in contact with patient, and that this classification simplifies what kind of disinfection or sterilization those equipments will need. Spaulding has divided the items as critical items are those items that come in contact with sterile body tissue of that patient. So critical items are those items that penetrate soft tissue, bone, or the vascular system, or through which the blood flows, such as the implanted medical devices. And undoubtedly, these critical items should be sterilized. Then we have got some semi-critical items. These semi-critical items, they touch either the mucous membrane or the non-intact skin. And most of the equipments that we use in our anesthesia practice, apart from the vascular access devices, most of them are semi-critical items. The endoscope that we use or the surgeon use is a semi-critical items. And all semi-critical items should undergo at least high level of disinfection. Then we have got non-critical items. Non-critical items are those that come in contact with intact skin, such as the bedpan, the blood pressure cuff, and the bedside tables. These should undergo at least low level of disinfection. We have got some excellent sources of material regarding disinfection and sterilization. The Center for Disease Control, CDC, guideline of disinfection and sterilization in healthcare facilities 2008, which was updated in 2019. Then the National Guidelines for Infection Prevention and Control in Healthcare Facilities by Ministry of Health and Family Welfare, Government of India. And then Hospital Infection Control, control manual for small, for small healthcare organization by NABH. So these are some excellent sources which are available free, for download. Now let us see the recommendation of frequency and process for operating room. What structure the operating room should be, what kind of the material that has already been done by Balabhaskar sir, sir. Here we shall be just touching upon the cleaning and disinfection part of operating room. The CDC guideline says that an operation room should be cleaned and disinfected before the first procedure, in between surgical cases, as well as after the end of the last case, that is known as the terminal cleaning. Now, before the first procedure, we should wipe all the horizontal surfaces of the room, for example, the furniture, the surgical lights, the operating bed, and the stationary equipment with an disinfectant, so as to remove any dust that might have accumulated overnight, because dust causes accumulation of organisms and they may become airborne, and then they can settle in our equipment that can lead to cross-contamination. Then we should also thoroughly clean and disinfect portable patient care equipments that may not be there in the operation room, but which would subsequently be brought into operation room. For example, the ultrasound machine when we are planning to give a block, or the C-arm when we are planning to use it, or the anesthesia trolley, or for the fact any machine. Those machines should also be cleaned and disinfected before they are brought inside the OT. Then before and after each procedure, we should remove all the linen and surgical drapes into an appropriate container. Then waste should also be removed, and it is necessary to remember that the waste collecting bag should not be more than 3/4 filled, and that we should also remove the kick buckets for reprocessing or disposal. Then before the start of next case, the high touch surfaces like the light switches or the doorknobs or the rotary knob of our anesthesia workstation, all these things which are outside the surgical field should be cleaned and disinfected. Then any visible blood or body fluids outside the surgical field, suppose on the wall or the floor, it should be appropriately dealt with. If a blood spill is less than 10 ml, then it is regarded as a small spill, and this should be immediately covered with an absorbent material like a paper towel or something like that. Then it should be covered with 1:100 dilution of 5.25% sodium hypochlorite solution, and then subsequently it should be wiped off. And if the spill is large, that is more than 10 ml, then instead of 1:100, we should be using 1:10 dilution of 5.25% sodium hypochlorite solution. Then all surfaces, whether it's a high touch or low touch, and the floor inside the surgical field should be cleaned. After the final procedure, that is the terminal clean, all the surfaces, whether it's a high and low touch surfaces, the vertical surfaces, the hand washing sinks, scrubs and utility areas and sinks, and the entire floor, not only the operative area floor, the entire floor should be cleaned and disinfected. The cleaning should be done with water and detergent, and then an appropriate disinfectant should be used. And while cleaning the floor, we should take care to move the operation table and any other mobile equipment to make sure to reach that the flow which is underneath those tables. And it is necessary to thoroughly clean and disinfect those portable patient care equipments like ultrasound or C-arm that were brought in for that surgical procedure, and then ultimately they will be shifted to a storage area. CDC does not recommend fumigation or routine fumigation of operation theater. The National Guideline for Infection Prevention, which is given by Ministry of Health and Family Welfare, they recommend that the surfaces must be routinely cleaned first with detergent. The detergent should be such that it should have a pH of in between 6 to 8 to remove any foreign and organic matter, because presence of foreign or organic matter will decrease the efficiency of the disinfectant that will be used subsequently. A detergent disinfectant combination, if it is available, can be used. Then there is no need to clean at first and then use this disinfectant. Wet vacuuming of the floor is preferred method to clean those floors. And if we do not have wet vacuum, we can also go ahead with wet mopping. Dry vacuuming or dry mopping is not recommended because it increases the production of aerosol, which increases the dispersion of microorganisms in the air. Then while mopping, the 3-basket system is to be used. When sending an equipment for sterilization, there are different methods of sterilization. One is where heat is used, that is the heat sterilization. The heat can be either moist heat or it can be dry heat. And in certain cases, chemical sterilization can be used, for example, ethylene oxide, where when the material is either heat or moisture sensitive. And then we have got low temperature sterilization, which are basically chemical sterilization, like plasma sterilization using peracetic acid or hydrogen peroxide. This can be used if the material which is sent for sterilization is heat or moisture sensitive. CDC has given extensive recommendation regarding sterilization, how to sterilize, how to monitor sterilization. Here I have mentioned only a few salient points. CDC recommends that steam is the preferred method for sterilizing critical medical and surgical instruments that are not damaged by heat, steam, pressure, or moisture. Then they have recommended to use, they have recommended that the manufacturer of the instruments, the guideline which is given by the manufacturer of the instrument, the sterilizer, the container or the wrap in which the instruments are wrapped, that are consistent with the guidelines published by the government agencies or professional organizations to which your institute may be affiliated are to be followed. In those instruments where heat, steam, pressure, or moisture can cause damage, they have recommended to use low temperature sterilization techniques like ETO. And whether we use ETO or whether you use steam or dry heat, there should be some time that is to be given for the instrument before they are used. Because if an instrument has been sterilized with ETO, then complete aeration of the surgical and medical items is to be done before that item is used. They have said that peracetic acid immersion system can also be used to handle heat and moisture sensitive surgical or medical equipments. But critical items that have been sterilized by peracetic acid system must be used immediately, unlike those by autoclaving or by use of ETO. Dry heat sterilization can only be used on substances that can withstand high temperature, like some powders, oils, or some natural suture materials. And CDC recommends to comply with the sterilizer manufacturer instruction regarding the sterilizer cycle parameters for any kind of sterilizing system that we are using. Now, chemical disinfection. Chemical disinfection, if you compare to sterilization, it is convenient, rapid and cheap, but it can never be an equivalent to sterilization unless and until we are using chemical sterilant. The problem with chemical disinfection is that they can be toxic, flammable, or corrosive, or chemical incompatible with certain devices. That is the reason why it is necessary to to look for the manufacturer recommendation on which type of chemical disinfection to be used on which kind of equipments. Chlorine releasing compounds are very commonly used in our operation theaters, but chlorine releasing compounds have corrosive effects and are not to be used on some semi-critical items, because if they are used apart from corrosion, they will also cause irritation in patients if they are not cleaned properly. Unfortunately, chemical disinfection can be affected by various factors, which we will see in next slides. And following disinfection, items are to be rinsed with water, dried, and stored in such a manner that it prevents recontamination. I'm extremely sorry, it's a very busy slide, but if we look into the columns of the slide, here we see that it shows the name of the disinfectant. The disinfectant can be used singly, or they can be used in combination with another disinfectant. There are various dilutions or various concentration of these disinfectants which are available. And for each dilution or concentration, the exposure time is different. Therefore, it is recommended that every facility should have their written policy regarding which disinfectant is to be used, at what dilution, for how long, for which equipment. Otherwise, it becomes very confusing. I was talking about that, unlike sterilization, chemical disinfection suffers from few setbacks. There are many factors that affect the efficiency of disinfection and sterilization. Some of those factors are the number and location of the microorganisms. That is the reason why all equipments should be cleaned very nicely before they are sent for chemical disinfection. For many, disinfectant, there is an innate resistance or microorganisms which is being observed. For example, the low-level disinfectant that we use mostly to mop floors, there are incidents to some of the common microorganisms that are observed in the OT environment. Then the concentration and the potency of disinfectant can also play a role. There are many physical and chemical factors that can affect efficiency of the disinfection system. Presence of organic and inorganic matter has already been discussed. Then the duration of exposure is very important, and presence of biofilm will obviously decrease the efficacy of disinfection or sterilization system. Let us just see a few points regarding instrument cleaning process. Actually, this slide should have come before sterilization and disinfection. Sorry, this slide came a bit later on. Anyway, cleaning is the first process to decrease bioburden. Cleaning can be manual or mechanical cleaning. In our OT, we still do manual cleaning. While we do manual cleaning, the rinsing of the equipment should be under cold water and it should be under running water, and the equipment should be opened up if that can be opened, because if we do not open the instrument, then some of the organic matter will not be washed away. Then it should be done under cold water, that is in and around 25 degrees Celsius. Otherwise, this might cause denaturation of the proteins which are on those instruments, and that can cause problem with disinfection. And this should be done under running water. Otherwise, brushing of those equipments will lead to generation of aerosol that will cause cross-contamination. That is the reason the cleaning should be done, or the brushing should be done under running water. And if you are using mechanical cleaning, then it is well and good. It is an automated process. Many instruments, they would need use of manufacturer recommended lubricants. Otherwise, the hinges will simply stop working and there will be buildup of backed-on protein. And then subsequently, they are allowed to dry. And after drying, they should be packaged so as to send them for sterilization. Now, coming to sterilization and disinfection of anesthesia equipments. As I have already said, most of the anesthesia equipments that we use are semi-critical, except a few. This excellent article in Indian Journal of Anesthesia is a very good resource material for cleaning and sterilization of anesthetic equipment. You can always refer to it. It's a freely available article. And then this article, which was published in British Journal of Anesthesia and Education, it is a containing education in anesthesia, critical care and pain, which is a sister journal of British Journal of Anesthesia. It is also an excellent source. And American Association of Nurse Anesthetists has published an extensive, manuscript on infection prevention and control guidelines for anesthesia care. This is also freely available. Now coming to scrub. Scrub should be worn in the semi-restricted and restricted areas of the surgery department, that is operation theater. That should include head cover, mask, scrub suit, warm-up jacket, which probably is not necessary for India, and shoes. The scrub should be healthcare facility approved. It should be clean and freshly laundered surgical scrub or anesthetic scrub suit. If the anesthetic scrub is contaminated with blood or body fluids or other potentially infectious material, it should be changed as soon as possible. Otherwise, we should wear a clean set of scrub each day and to change it to a clean scrub if contamination occurs. Though there is a confusion regarding whether it should be the washing of the scrub should be done in the healthcare facility or at home. American Association of Nurse Anesthetists recommends that home laundering scrub is acceptable if they have not been contaminated with blood or infectious material, which is very difficult to detect many times. So mostly it is regarded that this scrub should be health facility laundered. Now coming to OT linen, we should consider all OT linen as to contaminated if it is used during a process. Then the person who is handling those OT linen after the procedure is over should be wearing appropriate PPE. Then they should be carried in a covered container or plastic bags. Then they carefully sorted, the linen should be carefully sorted in the laundry area before washing. It is not recommended to have the laundry area near the operation room. And the corridor through which these dirty linens are taken should be totally different corridor. There should be barrier from the protected and semi-protected area. We should always be aware that the OT linen may cause sharp objects that can cause unintended injury. And routine decontamination prior to washing is not necessary unless the linen is heavily soiled. Before washing, the soiled linen should be separated from a non-soiled linen, and the soiled linen, they can be treated with sodium hypochlorite solution, and all linens should undergo first cold water washing with water temperature in and around 25 degrees Celsius, and then it should be washed with hot water of around 71 degrees Celsius. Now coming to microbiological monitoring. The microbiological monitoring of OT environment can be of mainly two types: the microbiological monitoring of the sterilization and monitoring of the environment of the operation theater. The sterilization can be monitored apart from microbiologically, either by mechanical method or chemical method, and microbiological surveillance of the operation theater can be routine, or it can be during an outbreak. In mechanical indicator of sterilization, we should look into the sterilizer gauges, the gauges of the autoclave, then the computer display of some advanced autoclaving machines, their printouts and documents to see whether the endpoints of the sterilization in regards to the pressure, temperature, the exposure time has been reached or not. Then we have got some chemical indicators that are sensitive chemicals that change color when exposed to high temperature or combination of the time and temperature. They are mostly applied over the package of the instrument that is to be sterilized. And most of the time they change color. And the very commonly used is the autoclave tape, which we see that once the item is sterilized, there are some black stripes on the autoclave tape. CDC has again given extensive recommendation regarding monitoring of sterilization. Here I have used only some of the salient points. CDC recommends to use mechanical, chemical, and biological monitor to ensure the effectiveness of the sterilization process. They recommend to monitor each load with mechanical and chemical indicator. And if the internal chemical indicator is visible, then the external indicator may not be needed. They recommend not to use any process items if either the mechanical or the chemical indicator suggests that the processing of sterilization has been inadequate. And CDC recommend to use biological indicator to monitor the effectiveness of sterilizer at least weekly. And the biological indicator for different sterilizer systems are different. When we talk about microbiological monitoring of the operation theater, it can be either the surveillance of the air, which is inside the operation theater, or surveillance of the surfaces, or surveillance from the equipments, or it can be surveillance from the operation, the persons which are present in the operation theater itself. CDC says that routine surveillance is neither warranted nor cost effective. So they no longer recommend a routine air surveillance or surface surveillance or equipment surveillance. But they say that targeted sampling for defined purposes may be undertaken. And some of the example of targeted sampling of defined purposes are when the operation theater is modified or renovation is done, and where there's an unforeseen increase in incidence of infection, where epidemiological epidemiological investigation suggests that some breach of the sterilization process in and around the operation theater might have played a role. Now, a few points about ultraviolet germicidal irradiation. The wavelength of ultraviolet radiation ranges from 328 to 210 nanometer. Its maximum bactericidal effect occurs in and around 240 to 280 nanometer. And ultraviolet, there are different types of ultraviolet ray, A, B, or C. It is the ultraviolet ray C, which is used for disinfection. It inactivates the microorganisms because of destruction of nucleic acid through the induction of thymine dimer. In this image, we see some ultraviolet germicidal lights which are fixed onto the ceiling, and they are switched on when there is no one inside the OT, mostly throughout the night. And then it is thought that they would decontaminate the air as well as the surfaces. There are mainly two types of ultraviolet germicidal irradiation devices. One is the installed UVGI, which I have shown you in the last image. Studies show that this can produce ultra clean or nearly ultra clean air, and it can be used for a nightly and in between case disinfection. And there are some portable UVGI devices, which is shown in this image, which can be brought in inside the operation room. There are two types: the low pressure mercury lamp that emits a continuous, ultraviolet ray, and there are xenon lamps that emits very, pulses of ultraviolet rays. Whatever system that we are using, we should be keeping in mind that ultraviolet C is very toxic to human. So appropriate precaution is to be used. Mostly these devices is to be stopped before around 2 hours prior some person enters the operation theater. And many times they have been used when the persons are using protective gears. Ultraviolet radiation, though it seems very attractive, it has got several potential applications, but unfortunately, its domiciliary effectiveness and use is influenced by the presence of organic matter, the wavelength that is being used, the type of suspension, temperature, the type of microorganism, the intensity of UV light, which is affected by the distance. More is the distance, less is the effectiveness. And with time, the tube becomes dirty, and dirty tubes, we are not very sure how much UV radiation is coming out of those tubes. The application of UV radiation in healthcare environment is limited because destruction of airborne organisms or inactivation of microorganisms on the surfaces may not be very good for porous, porous equipments. And CDC says that more research is required to clarify the effectiveness and reliability of UV irradiation for environmental decontamination. Now coming to the last part of my topic, biomedical waste. Handling of biomedical waste is governed by the Biomedical Waste Management and Handling Rules 1998. In fact, it is a law which were amended in 28 March 2016. So this whole document is freely available on the internet, and I request all the delegates to download it because it's a quite extensive but very clear piece of document. Biomedical waste should be segregated into containers or bags at the point of generation, that is in the operation theater. This should include placing different types of waste in different color-coded bags and containers at the site of generation. This should be placed in such a way that they do not contaminate the sterile surgical field, and the contents of those bags can be taken away through a dedicated corridor which is away from the protected and semi-protected area of the operation theater. The color-coded bags should be as per national norms. The plastic that is used should also be as per the national norm. And there should be placed in appropriate containers with appropriate label or logo. These two logos are commonly seen. On the left hand, it is the biohazard symbol, and on the right side, it is the cytotoxic hazard symbol. These symbols should be clearly marked on the containers, as well as the trolley through which these containers or the bags would be taken to the central point. The solid waste is to be collected in leak-resistant heavy-duty bags so that they do not leak either during storage or during transportation. The colored bags should be made of non-chlorinated plastic with biohazard sign and labels mentioning the date and details of the waste that are to be used. The bags are to be tied tightly after they are 3/4 full. There must be provision to made within the operation theater premise for a safe and ventilated and secured location for storage until and unless they are taken away. And there should be separated from the protected and semi-protected zone. The area should be inaccessible to scavengers and protected against insects and birds and animals. Otherwise, there is a chance of cross-contamination. And the areas, we should ensure that there is no secondary handling or pilferage of the recyclables. Biomedical waste guideline, it recommends that anatomical waste, whether it's a human or animal, soil waste, expired medication, chemical waste, linens contaminated with body fluids, clinical laboratory waste should be stored in a yellow non-chlorinated plastic bag, and then they should be treated and disposable as per the recommendation of the law. The contaminated waste recyclable like plastic tubing, they should be stored in the red colored non-chlorinated plastic bags and containers. Water salts, including metals, they should be stored in white and translucent puncture, leak, and tamper-proof containers, and subsequently taken for treatment and disposable. And glassware and metallic body implants should be kept in, blue cardboard boxes. Cardboard boxes with blue markings. At last, I'd like to mention a few points about operation room etiquette. It has been seen that the majority of healthcare-associated infection results from cross-transmission, whether it is from the host or whether it is from the environment. And we have learned that transmission from the host is, the most likely, source of contamination, not from the air or the environment of the operation theater. Nonetheless, this contamination has been seen to be related to inappropriate patient care practices. And some very recent observation studies suggest that even in highly developed countries, there is very low adherence to published guidelines. And it is seen that there are many human behavioral issues that actually leads to low adherence to the published guidelines. So it has been suggested that modifying health workers' behavior might be a key in maintaining sterilization and infection control policy in in operation theater. So the basic operation room etiquette, like maintaining of the sterile field, all those things has to be followed diligently. Thank you all for your patient hearing.
Thank you very much, Dr. Priyam Saikia. Excellent presentation. I think you have covered practically all aspects what we are trying or doing in day-to-day practice. Of course, our standards and the practices may be slightly different, or maybe we are falling short of the recommendations made by the relevant agencies, including the law. But it does not form a controversy. It is only that we are not able to follow it, or we are not up to the mark. We should make all efforts to see that the patient is kept safe, the healthcare workers are kept safe, so that the infection is not spread. Both the parties should be protected. That's what is the current concept of that. Thank you very much. And any questions, we will take it at the end. And Sanish, is it possible? Yeah, it is about this talk. We are just playing it, the troubleshoot, because he could troubleshoot the thing. The first question is, how frequently should we do fumigation of operation theater? You have already heard. I expect all the participants to answer correctly. Daily, thrice a week, once a week, or none of the above. You have got 20 seconds time. Okay, 25 out of 87 people. 28. Okay, so 30 people have voted and they have said that none of this, that is daily, thrice a week, or once a week, that particular thing. But the answer is, he has already very, very clarified. Clearly, he has told that it should be carried out at a any definite specific interval, especially when you do renovation or some activity in there. Otherwise, it is not always necessary. Okay, next one. There is a spillage of about 100 ml of blood on the OT floor while operation is going on. So what should we do immediately? One is mop it with a soap and detergent, or mop it with benzyl chloride solution, or cover it with a paper and then apply this 5.25% of the hypochlorite bleach solution, or cover with the paper and then apply glutaraldehyde solution. Your answer, please. Voting pad is active.
Sorry, sir. Voting pad is not coming now.
Not working. Okay, you can put it in the answers can come in the chat box. Yeah, I'm seeing C. Okay. Okay, that's a right answer. The C is the right answer. You cover it with the paper and then apply the hypochlorite solution what we are using it. Okay, the next question. The scrub that anesthesiologist wears, that is the dress that he wears, it should be changed daily and laundered at the healthcare facility, or it should be changed daily and laundered at home, or it should be changed thrice a week and sterilized, or it should be changed thrice a week and decontaminated with the hypochlorite solution. Answers are appearing in the chat box. A. Okay, A. Right. I think almost all of them are agreeing with the right answer. I'm very happy that the Priyam Saikia is able to drive home the point that it should be changed daily and laundered at the healthcare facility itself. There is no need that you should take it home. Okay, that's a nice thing. And there is another question. To decrease the surgical site infection, the swab OT must be sent, that we take every week or every month, once a month, anytime the patient with the gas gangrene is operated, once a year, or anytime after the renovation of the OT. When do you think should be the? Please, your answers in the chat box. A, once a month. A. One person has answered D. Remaining are all answering okay. D again. Okay, the right answer is, I'm afraid many are saying it is A, but the right answer is anytime after any activity, renovation or any activity that takes place. Okay, B is definitely not the this thing. You have to do it whenever a gas gangrene is operated. the site need not be, I mean, sample need not be taken and sent. You need to go straight away for a cleaning and sterilization of the OT. So this should be done. The question is, to decrease the surgical site infection, the OT swab must be sent. You have to take the swab. Okay. Go to the next question. Okay, so that's this thing. And with this, we will come to the end of the third talk, and we have got the last one. This topic will be dealt by Dr. Amit Shah. Amit Shah, he is going to speak about the ventilation aspects in the operating room. That is ventilation. It includes the air handling units, the filtration, HEPA filters, what is the temperature, how much air exchanges should be there. And also the positive pressure, negative pressure. I think a lot of interest was generated during the COVID pandemic about the negative pressure OTs. And just to give an introduction about Dr. Amisha, I think he is one of a great personality in the airway field, but also it is my, just as a customary practice, he is one and the only one partner of this Patwa Shahi video laryngoscope. I think we should be all proud of the anesthesiologist trying to do an invention. And also the high flow nasal oxygen device, they are the team members, they are the ones who are the inventors. He is actively involved with the Airway Society, that is All India Difficult Airway Association, and he is one of the awardee, that Bhopal Award for the academic excellence from the ISA in 2017, and he has got several publications. The best thing that goes to his credit is his first Indian difficult airway guidelines, what we read. He is the co-author of that. And over to you, Dr. Amit Shah, for your talk on this ventilation in the OT. And before we start that, just two questions we will have, three questions. According to NABH standards, HEPA filter is a must for ophthalmology OT. Okay, already know, somebody is telling, any more people know. The voting pad is active, you can participate through voting. Okay, I'm very happy that pad is working now. 31, 34, 35 people. Right, 20 seconds. There is a little ambiguity about this, but the right answer is B. The option B, 21 members have answered it correctly. Nevertheless, why it is not a mandatory thing according to NABH, Amit Shah is going to clarify. In the meantime, we'll go to the next question. According to NABH standard, once again, the minimal fresh air exchange needed for a total air exchanges is how much should be air exchanges every minute? That is 20%, 40%, 60%, or 100%. Okay,
we'll use the chat now.
Okay, use the chat box and please answer A, D, A, B, A. Okay, somebody is answering B, A also together. Right, the right answer is 20% that is sufficient so that the complete air exchange takes place. Okay, these will be again dealt with by Dr. Amit Shah. Next one, the minimum coverage area of a laminar airflow beyond diffuser array should be how much? It should be 12 inches or 24 inches, 36 inches or 48 inches. I know many people may not have been exposed to the laminar airflow system. He is going to clarify, but however, I expect the answer from the experts. B, C, B. Okay, B, right. Not many are I think familiar with this particular topic, it looks like, and it's the responsibility of Amit Shah to clarify this. The right answer for this is option A, that is 12 inches. How and all, we are going to let you know during the course of the talk. And another last question, that is, according to the current standards, the operation theater should be a positive pressure area or a negative pressure area? Your answers, please. Okay, there is A, there is B, there is A, B. Okay, both options are coming. Right. Okay, during the COVID pandemic, we did discuss about the negative pressure area, but otherwise it is normally the positive pressure area. All operation theaters are positive pressure airways. That's how the laminar airflow functions. Okay, these are some of the questions, and nevertheless, those who are not answered correctly, we will listen to him what exactly it is. Okay, Dr. Sanish, to play the recorded version of this.
Good evening, dear friends and colleagues. At the outset, I would like to thank Dr. Harsur sir and Dr. Balabhaskar sir for keeping me part of this ICA webinar on all about operation room. I'll be speaking about operation room ventilation system. There is no conflict of interest for this particular lecture. The information which I'm sharing from this lecture has come from these resources. There are two most important resources which I have included here is the NABH standard, which is revised guideline for air conditioning in operation theater published in latest in 2018. And then ASHRAE standard. ASHRAE is American Society of Heating, Refrigeration and Air Condition Engineers. And even NABH in their sources have cited ASHRAE guideline for operation room ventilation. So NABH has broadly classified for the purpose of operation room ventilation, the operation theaters into three categories. One is super specialty operation theater. That includes where neuroscience, orthopedic joint replacement, cardiothoracic and transplant surgeries can be done. Then general operation theater, which includes all other categories of operation theater, including ophthalmology. And then the daycare surgery, where admission of a selected patient to hospital for a planned surgical procedure, where patients are returning home on the same day. But the operation room ventilations are more or less same for the general OT and daycare surgery. And also between super specialty and all other operation theater, there are very minimum differences are there as far as operation room ventilation is concerned. So primary objective of hospital operating room ventilation system, which is also called HVAC system, is to minimize surgical site infection, which can occur due to airborne contaminants and bacteria. And this also provides comfortable environment for the surgeon and other operating room personnel in the room. The key factor in reducing surgical site infection is to minimize contamination of the sterile zone where patient himself is operated and the equipments which are there in that particular sterile zone, and including the operating room personnel which are there in the sterile zone. During surgical procedures, additional dust particle, textile fibers, skin scales from the operating room persons and respiratory aerosols, which are loaded with viable microorganisms, are released from the surgical team. And they are released into surrounding air of the operation room. And those bacteria and other microorganisms which settles on the surgical instrument, or those who can directly enter into the surgical site, may result in the surgical site infection. So to prevent surgical site infection and give comfort to the operating room personnel, goals of operating room ventilation is to provide unidirectional laminar airflow which enters from the ceiling and exhaust via grills in the wall close to the floor. This flow, which is a unidirectional flow, has to be of sufficient velocity to provide required air changes, which removes airborne particle out of operation room and provide clean air with the help of various filters. There should be positive pressure inside operation room to prevent entry of the surrounding area air into operation room, and also should maintain appropriate temperature and humidity for the comfort of the operating room personnel inside the OT, operation theater. Now, there are three major parts of the HVAC system. Heat, ventilation, air conditioning system is also called the HVAC system. Now there is an air handling unit, which if you have only worked in operation theater, you may not have seen that. That is there on the probably floor above or the other area adjoining your operation theater, which is also called air handling unit. It has a return air and a fresh air inlets. It has various filters, motors, and chiller and humidification system for maintaining temperature and the humidity. Then you might have seen a diffuser grill, a grill right in the operation theater, right above the operation theater table, which is called diffusers. And preferably the HEPA filter, which are the best among all filters which are installed in the HVAC system, preferably has to be there in the diffuser. And then on the side wall, you might have seen exhaust grill from where return air goes to the air handling unit. Now, air handling unit is basically a big metal box with on a metal framing system. There are two types of unit which are there. One is draw through and second is blow through. There are two filter section as per the NABH guideline. One is to be pre-filter, which provide dust-free clean air. According to this ASHRAE standard, they are reported as MERV standards. So minimum efficiency reporting value, MERV MERV standards, and they are okay if it has a low MERV standard, which are of the 7. So essentially it removes the larger particle. Then there are cooling coils, which can be of a various technologies can be used, like direct expansion or chilled water technology can be used. And then there are humidifiers to humidify air to a proper percentage, and they can also be spray type, steam pan type, or a steam grid type. Now there could be other technologies also. These are generally used technology in the air handling unit of the HVAC system. Then there is a mixing chamber where the returned air and the fresh air are mixed in the appropriate proportion as per the requirement of the air handling unit. And then this air is supplied through diffuser in the operation room, which is directly over the operation theater table. And then this air is returned through the exhaust grill. So to achieve proper clean air of the HVAC system, there are specific requirements. Like there has to be proper filtration of air. Then it should provide proper airflow, which has to be in the unidirectional towards operation theater table. Then you have to maintain temperature and humidity inside operation room. There has to be effective exhaust of the circulated air. And then you have to maintain positive pressure area so that surrounding air does not enter into the operation room. So for the filtration, NABH standard says that AHU must be an air purification unit and air filtration unit. There must be two sets of washable flange type filter, which reduces efficiency efficiency 90% down to 10 micron and then 99% down to 5 micron. And then HEPA filters of efficiency of 99.97% down to 0.3 micron or a smaller has to be provided in the air handling unit. So air handling unit preferably should have two sets of filter, which reduces efficiency down to 5 micron. Third, filter should be preferably in the diffuser, which is in the operation room. If it is not feasible to put it in the operation room, it can be kept in the AHU unit also. Now, for the super specialty operation theater, HEPA filter is must, while in case of general OT, as per standard, it may or may not be provided. It is preferably it should be there, but in absence of HEPA filter also, it is acceptable as per as the NABH standard for the general operation theater. So the word they've used is it may be provided. It is not must, as it is written in the super specialty operation. Now, what is HEPA filter? HEPA means high efficiency particulate air or arrestants. They are basically a mat of randomly arranged fibers which are made up of a plastic or a fiberglass. They are high efficiency. They capture all the particle like pollen, dirt, dust, moisture, bacteria, virus of small size and submicron liquid aerosol also. They capture this particle via three methods. One is called the straining. That means the larger particle just cannot pass through the fibers. Then the smaller particles between 0.3 micron to 1 micron are intercepted, as the air can move around these fibers, but this heavy particle will not be able to move with the air, and they will be intercepted. And then very small particles, which has its own movement, which is called the Brownian movement. They'll also not be able to follow the air pathway, and they will again get intercepted. So there are three methods which are described, which is called the straining, interception, and the diffusion, used by the HEPA filter to filter even nanoparticles. Now, airflow has specific requirements like proper air exchanges, proper air velocity, then airflow pattern, which is unidirectional and it should pass through the grills, and this also maintains the positive pressure. So NABH guideline says that OR should maintain positive pressure with total of 20 air exchanges. So within 1 hour, this entire air should be replaced 20 times. And out of this 20 times, minimum 4 fresh air exchange. That means 20% fresh air should be exchanged. Now, preferable and the best scenario is the total fresh air exchange. That means whatever air comes into the operation theater is the fresh, and then the air which goes to the exhaust grill goes out directly into the atmosphere. But this is a very costly affair and requires various additional devices like heat recovery wheel, run around pipes, and etc. And that is how it is not mandatory to use total fresh air exchange in operation theater. You can use recirculating air. The supply air should be unidirectional, which is called the laminar airflow, which flows directly towards operation room, operation theater table, and it also travels slightly laterally on the 15-degree angle. It should be at the discharge velocity of 25 to 35 FPM. This will cover the surgical area very well and prevent any other particle from the surrounding air. It prevents entry of particles from the surrounding air into this particular area, and this only clean air pass through the patient and the pass over the patient and the surgical team. The diffuser area from where the air comes into the operation theater should be provided directly over patient and the surgical team, and the coverage area of diffuser area should be at least 12 inch beyond the operation theater edge, operation theater table edge. So whatever operation theater table edge, it should actually extend beyond 12, at least 1 feet or 12 inch. As the laminar airflow goes towards operation theater table, near floor, it goes towards exhaust grill, starts going towards exhaust grill and then comes out. But the air which is there in the other area above the floor area, so in the upper section of the operation theater, away from this discharge area, can actually circulate into the operation room. Now, during this circulation, it moves from non-sterile zone towards sterile zone, and entrapment can occur into the sterile zone from this non-sterile area. So it is not only our purpose just does not serve just by providing a bacteria-free air from the diffuser area. Airborne particle concentration may be generated if airflow in the surgical site becomes turbulent. That means in the other area which is not covered by the diffuser area and the laminar airflow, air can become turbulent. The turbulence can increase with improper position of supply diffuser and exhaust grill, by opening door, by blocking the exhaust grill by the equipment, or circulation of operation room persons. So too many persons, too many times if your door is opening, and if there is too much of movement in the operation room, this turbulence can increase, which increases chances of entrapment of the microorganism and particles into the sterile zone or onto the sterile area. That means on the tray or the table where surgical instruments are kept. So essentially, there has to be minimum number of necessary personnel should be inside operation theater. The guideline which is given and the air exchange which is provided for 5 to 8 persons inside operation room. There has to be minimum number of extra equipment should be inside operation theater, and unnecessary, the equipment which are not to be used in that particular operation should be kept outside the operation. This should avoid this. We should not put equipment directly in front of the exhaust grill, which will block the flow of the air. And unnecessary door opening should also be avoided. So exhaust grill is very, very important. Size, location, and number of exhaust grill play an important role in determining flow path of the airborne contaminant. ASHRAE recommends, and also NABH recommends, that on each side, at least 2 low sidewall exhaust grill should be placed at the opposite corner, and bottom of this exhaust grill should be installed at least 8 inches above the floor, and equipment and table should not block this exhaust. Now let us discuss about positive pressure room and the negative pressure room. There are a lot of discussion in this COVID time about creating negative pressure room. Now what is positive pressure room? Here higher pressure is maintained inside the treated area than the surrounding environment. So essentially, positive pressure room allows staff to keep vulnerable patients safe from the infection and disease. So non-infected patient will not get infected from the surrounding air and the surrounding personnel. Well, in case of negative room, pressure uses lower air pressure inside that particular area, and then the surrounding air can go into the negative pressure. So the advantage of this is it traps and keeps potentially harmful particle within that negative pressure room. So the infected patients are kept in the negative pressure room, which will isolate the patient and prevent infection to the surrounding area and surrounding personnel. Now, as per the current standard, operation room is a positive pressure area. Our primary job is to prevent infection to the patient from the surrounding area. Only during COVID time, there was additional discussion about creating negative pressure room, but so far our standard says that operation room are positive pressure area. NABH recommends that minimum positive pressure should be 2.5 pascals or 0.01 inches of the water should be maintained inside operation theater. Now, how does this is created? So positive pressure is created by giving more air compared to the return air. So 85% air is only returned from the exhaust grill. So 15% extra air is delivered from the diffuser array, which is not going outside the operation room through exhaust grill. And that is how a positive pressure is created inside the operation room. Now, humidity has a very important consideration for the comfort factor. NABH standard says that 50 to 55% relative humidity should be there, and the range which is described in ASHRAE is 20 to 60. Now, a relative humidity of 50% helps to dissipate the electrostatic charges, which can be hazardous in the oxygen-rich environment. So it is important that we maintain it at the 50%. Low humidity will cause drying of mucous membrane, can cause hypothermia of the patient, and it increases the floating particle in the operation room atmosphere, which increases chances of wound infection. So low humidity is hazardous, it should be avoided. High humidity will cause sweating, and in fact, your surgeon will ask you to open the operation room door and the other area, and which increases chances of infection. So high humidity or low humidity should be avoided. Temperature again mainly needed for the comfort factor. It is recommended that it should be maintained at 21 degree plus or minus 3 degree for the routine operation theaters, and only for the ortho or joint replacement operation theater recommendation is at the 18 degree plus or minus 2 degrees. And to maintain this temperature, split air condition or window type of air conditions are strictly prohibited, because they create pockets of air, pockets of area where organism can settle down and can increase chances of surgical site infection. So split AC or window type of AC are strictly prohibited in the operation room. They are prohibited even in the area in the general OT or ophthalmology. Now, I'll also share a slide or two about scavenging system. The scavenging systems impact on a over-ventilation, or how you can manage scavenging disposal of the waste anesthesia gases in a various type of OR system. So we know what are the problems of waste anesthesia gas. It can cause nausea, dizziness, headache, fatigue, irritability, sterility, miscarriage, birth defect, cancer, and liver kidney disease among operation room staff, and some problem even among the spouse. And there are various recommendations by NIOSH, which says that any halogenated anesthetic agent should not be, the operating room personnel should not be exposed to concentrations more than 2 ppm over a sampling period of 1 hour. While hygienist engineers of America is also recommended threshold time value for time weighted average. That means a nitrous oxide 50 ppm for normal 8 hour. So there are various solutions which are already there, that, like, keeping a tight mask fitting, avoiding the spillage, keeping inhalation anesthetic vaporizer closed during when you take off the mask for the intubation, and so on. There are so many methods which are described, but one important consideration as per OR ventilation is the scavenging part. There are two types of waste gas disposal system. One is called active scavenging, second is called the passive scavenging. Active scavenging means you can connect the suction system. This active scavenging means you can connect the scavenging tube to the suction system of the hospital. And if your anesthesia machine provides active scavenging, it is good. You can use it with our OR room ventilation system, because it is directly connected to the central suction, and it is taken from the, and waste gases are taken from the patient or operation anesthesia machine to directly to the external suction system. Well, passive system, where gases are passively exhausted to the atmosphere by the higher pressure of the gases. Now, in non-recirculating OR ventilation, that means if the operation room is providing 100% fresh air, in that situation, you can keep the scavenging tubing directly to the exhaust grill, because from the exhaust grill, entire waste gas is going to go out into the atmosphere. But in case of recirculating OR ventilation, which is recommended by NABH, and majority of our operation theater of recirculating OR ventilation, where fresh air exchange is only 20%, you cannot put scavenging pipe to the exhaust grill of the HVAC system, because it is going to come back to the operation room, and HEPA filter is not going to absorb it. You need special substance to absorb these anesthesia gases. So what you need is a dedicated outlet which can directly go out from operation room to the atmosphere. There are various issues with this, but that is the only system possible if your anesthesia machine allows a passive system in a recirculating OR ventilation. So you need to create a direct passage into atmosphere for the passive system, while active system is good enough, you can connect to the central suction system. So, at the end, overview of an operation room ventilation system, HVAC system is must. You need at least minimum 20 air exchange with at least 20%, that is 4 fresh air exchange. There are 3 levels of filtration, including HEPA in operation theater. Diffuser is must for the super specialty, and also preferable in a general operation theater. Proper position of diffuser and exhaust grill is essential. An operation theater room is a positive pressure area, and proper temperature and humidity maintenance is of utmost importance. Thank you.
Thank you very much, Dr. Amit. I think it's an excellent presentation. Both the last 2 talks, just for to inform that these 2 topics, that is the sterilization and the ventilation aspects, including air changes in the temperature, they are the theory questions. Often they have appeared both in the National Board of Examinations as well as in the university examinations. So that's a special interest, theoretical. And during the YOOC, also some of the examiners will be interested to know about the size and the other issues about the operating rooms. But definitely these last two, sterilization issues and the ventilation issues, will be part of theory question. It is definitely beneficial to those people. And now the last part, that is we have completed the 4 talks, and any questions we will take before we go on to the last part, that is questions, a quiz will be there. What are the any questions that are appearing, Sanish, in the NABH recommends HEPA filtration for general OT also? That is the question that is asked. Already Amit has answered. Please clarify, Amit.
For it is must for super specialty operation theater.
Yes.
It is preferable that you should keep HEPA filter in general operation theater and ophthalmology, OT, and all other operation theaters. But it is not must. It is preferable that if you have facility, you should be able to, you should put HEPA filter even in other operation theaters, general and ophthalmology.
Right. And in the among the participants, I could see some of the highly senior and experienced people like Manjula Sarkar was there, Murlidhar Kanchi, Dr. Ambarish, Dr. Mary Korula. Any comments from you people, experts? The Sanish, you can unmute all these senior faculty members.
Okay, okay.
And questions, any questions are there? You can put the questions in the question box. The panelists will be happy to answer those things.
So from the audience, they can unmute and talk now, sir.
You can unmute yourself and talk also. Okay, in the meantime, I think, Sanish, shall we go ahead with the audience quiz?
Yes.
The questions, all the participants, be ready with the answer. Whoever answers the question first in the chat box will be suitably awarded with a certificate, appreciation certificate. Sanish, can you come with the question?
Shall I put the first question, sir?
Yeah.
Shall I put the first question, sir?
Please. The question number 1 is like this. Green operating rooms will involve minimizing the fresh gas flow during maintenance of anesthesia, turn off vaporizer during intubation, proper use of sharps and containers, sharp container, both A and C, or all of the above. Okay, the right answer here is, can you display the answer, Sanish? It is D.
On screen, sir. D.
The answer is D, and one Dr. Anjan is the one who has answered it first, along with, they are not given the name, Galaxy and Max, OPCA 786 is of course not. These are the 2 persons, Anjan and another gentleman on the, both have answered simultaneously, Galaxy and Max. You can contact Dr. Sanish on your, giving your name, the certificate will be awarded to you. Okay, the next question.
The winners are requested to send your name and email ID to me.
Right.
Okay.
Next question, please. Yeah, question number 2. Which is regarded as the main reason for surgical site infection? The microorganisms harboring in the host, microorganism present in the air of the OT, microorganisms present in the surgical drapes, or the microorganisms present in the surgical team members? Your answer, please. The answer is A. And the first person to answer this, please get ready for the audio. Yeah. Renita, and Anjan once again, and Neena Tripathi. These are the three people. No, only Renita and Anjan have answered it correctly.
Okay.
Please contact Dr. Sanishan with your name and email ID. He will be sending you the appreciation certificate. Okay, there will be another one.
No, only two are set, sir.
Only two, yeah.
Okay.
Right then. So thank you very much. And there are does not appear to be any more questions in the chat box. And any comments from my senior colleagues and friends? Dr. Ambarisha is there still? Okay, Dr. Mary Kurulam. Jayashree Sood, madam is there. Madam, your comments, please.
Yeah, good evening, Dr. Harsoor. What I just wanted to say was that, yes, this was, of course, a very important topic, but with the COVID that has come, not only the anesthesiologists who are always concerned about the OT and the OT concerns, the surgeons have also pitched in. Now they want to understand, madam, what is this AHU? What is this positive pressure? Otherwise, they couldn't have been bothered earlier. But nowadays, they're all interested to know what is this negative pressure system and things like that. So because of COVID, awareness about the importance of OT pressure system and AC has all, has been recognized even by the surgical team. And
yeah, that's very true, madam. Yes, madam.
Yeah, Harshul, we are learning a lot these days.
Yes, sir.
Especially as Dr. Jayashree was telling, the COVID made us learn a lot of things. And I'm not saying that COVID should continue, but COVID is helpful for us to get, very many ways COVID is helping. Anyway, this is an excellent conduct of webinar because we were telling of operation rooms, operation theaters and all these things, but we are knowing only very little about how to do things scientifically. But all the speakers were excellent. They were telling many, many things, but which I doubt in my India, whether we will be able to bring up all these things in the near future. Certain areas are rather welcome or rather benefited with certain facilities, but not all the things what is required. I request you, Harshul, if we can some certain things which is absolutely essential, or we should have that sort of pattern brought out in India in Indian theaters. Again, theaters and room, there is a difference even that most of our guys may not be knowing what is a theater, what is an operating room. And all the speakers, Zulfiqar, Balabhaskar, ICA, and I'm sure they were telling very, very high things, which is rather quite new to us. I'm so happy. Good to hear this particular webinar. And before Dr. Jayashree Sood is going to tell thanks and goodbye to everybody, I request Dr. Balgit, if he's anywhere here, give his impression on this today's webinar, how it was useful to all of us, and probably how it's going to shape our theater use in the future.
In the future, yeah. Sir, even Dr. Sunanda Gupta is there, sir. Can we unmute?
She can also join.
Madam,
yeah, everybody
Gupta,
is unmuted.
can you unmute and speak a word or two, madam? Okay, she's not there.
Okay, Dr. Jayashree, will you wind up the session?
right.
And
Yes.
tell us how all these things going to be useful to us in future. At least in 2-3 years time, we may have to achieve all the standard things which are being discussed. We are a wide country. It's not very easily possible for all these things. And again, theater is the last priority area even today, because they may spend money more on other areas. whereas theater area is the maximum money spending, money making area. But still, people are rather reluctant to put more money in. Anyway, these are all interim things. Probably it's all going to change soon. And I request Dr. Jayashi to have a summing up of things and how things should shape in future, and give the lot of thanks to everybody. Over to you,
Thank you,
Jayashi.
Dr. Radhakrishnan. Thank you, Dr. Radhakrishnan. Well, what I would like to say nowadays, of course, the administrators, of course, in the tertiary care hospitals, but other hospitals also, they are aware of the importance of OT. So it's not that the OT is not given preference, but then, of course, we as administrators who are the heads of the department should ensure that the minimum mandatory requirements of the OT should be there, as was so clearly pointed out about the HEPA filters and the other parameters that were spoken in the lecture. So it can be, so maybe in the ICA itself, we can have some protocol and then send it to the HODs, which I'm sure they're aware. It's not that they have to learn from us. The HODs should be knowing it. And definitely, again, as I said, because of this COVID, it has made us learn several things. So possibly this is in the minds of the administrators and because with this COVID, what happened was, we all know that so many changes were asked to be taken. They were asked for to be changes to be taken place so that these cases could be done. So it's not that people are not aware, the administrators are also aware. So I'm sure things will improve, and for the better, of course, things will take place. And it's my pleasure to be proposing the vote of thanks. It has been such a nice webinar. That was the topics again were so well selected, so well moderated by Dr. Harsoor. Thank you, Dr. Harsoor, so much.
Thank you,
And
madam.
of course, the lectures were also excellent. Dr. Balabhaskar, Dr. Zulfiqar Ali, Dr. Priyam, and Dr. Amit Shah. I have no words to express my thanks for all of you to have taken out your precious time at this hour for this lovely webinar and the interaction that we've had. Thank you very much. And last but not the least, thank you, Sanish, for doing all the logistics for it. Thank you, everyone. Good night, and see you all next Wednesday.